Okay, this is leucoma or leukomatous opacity in the center of the cornea. That was first finding. Then we have
Hypopyon.
we have a
Circumciliary.
hypopyon. We have a circumciliary congestion. Right. So these are the three main features which will tell us. All right, we have hypopyon, we have an opacity, and we have circumciliary congestion. So we have a sign of inflammation, another sign of inflammation, and a lesion in the cornea. So this is a hypopyon corneal ulcer. All right. So you've looked at this image closely. Let's compare it to the image in our second case. It's a little bit dark. But it's a representative lesion. इससे बेहतर मुझे कोई तस्वीर नहीं मिली थी इसकी. What do we see in this? What can we see, if we can see anything at all in this picture?
Hypopyon.
Right, there's a hypopyon present right around here. Remember one thing, we have an hypopyon.
And the corneal opacity.
We have a corneal opacity. All right. Before I mark the corneal opacity, we can see ciliary congestion around here and also here as well. थोड़ी सी image की वजह से we cannot appreciate it that much, but it's present. And yes, we have a corneal opacity. Right? There's a large central corneal opacity over here. So is there only one corneal opacity, or are there multiple opacities or multiple lesions?
Multiple.
Multiple. Where are these multiple lesions present? They're present on the other side. I'm not sure whether it's temporal side or nasal side, because I can appreciate on as much as you can do. So there's multiple lesions or opacities present over here. Now, what's peculiar about these opacities? Inka pattern या इनकी arrangement के बारे में, can you say something about their pattern or their arrangement? What do some? Okay, so there's a central opacity. The central large opacity, more or less circular nature, and then we have small opacities, which are orbiting. You can say it looks like they're orbiting this main lesion, this central lesion. So when we have a large central opacity and smaller opacities, which are arranged in a concentric manner, because it looks like they have the same center around here, and they are present equidistantly in a circular manner around the central lesion, then these peripheral lesions, the side pe chote chote nazar aa rahe hain opacities, these will be called. Does anyone know what they're called? Called satellite lesions. This is a buzzword. All right, keep this in mind. Satellite lesions. What are satellite lesions? You can imagine that the central corneal opacity is a planet, and this planet has lots of small satellites around it or orbiting it. So large central opacity with satellite lesions around it. Were these satellite lesions present in our first case?
Nope.
No, right. So coming back to our first case, we have a history of redness, photophobia, and tearing in this patient who presents with a large central corneal opacity, a large ulcer with a hypopyon, and circumciliary congestion as well. What is your diagnosis? Or what is your original differential diagnosis? The differential diagnosis will include, अभी थोड़ी देर पहले मैंने बताया कि हाइपोपियन में दो चीजें आ सकती हैं हाइपोपियन अल्सर. It can either be
Bacterial or fungal.
It can be fungal, right?
Fungal.
Matlab, this is what you have to see. If there's a hypopion ulcer at our level, at the first level, they will not go towards any complicated causes. They will simply, they will have two causes of hypopion ulcer. It will either be bacterial or it will either be fungal. So how can we know if it's a fungal ulcer or it's a bacterial ulcer? The first, we can go on clinical examination. and clinical examination relevant to this disease of cornea, is slit lamp biomicroscopy, right? Slit lamp पे तो हमने देख लिया, but we don't know what these lesions are or how we can, what the specific lesions are yet. अभी तक हमें नहीं पता कि फंगल में क्या होता है, बैक्टीरिया में कैसी specific lesions बनती है. So one way is slit lamp. Other way we can differentiate between the two is culture. So culture भी कराते हैं. Culture is a time taking process. Culture से पहले आप एक और काम करते हैं. जो आपके पास सैंपल आता है, आप उसकी स्मेयर की हिस्टोलॉजी करते हैं, स्पेयर माइक्रोस्कोपी. इससे क्या मतलब है कि you obtain a part of it, you place it, you stain it, and you immediately place it under the slide. If you're able to see the organisms, well and good. If you're not, then you have to wait for a culture. Culture means that you incubate the organisms, and after incubation they grow. Then you prepare a slide and you stain it, and afterwards you can visualize it under the microscope. So slit lamp examination, smear microscopy, and culture. All right. On the basis of these, we're usually able to form our diagnosis, and in clinical vignettes, also these are the two important examinations, important examination and the important investigation on the basis of which we can form our diagnosis. So in a bacterial corneal ulcer, what would you see on a culture or a smear microscopy? In order to know this, you must know which are the important organisms which cause a bacterial hyperpion ulcer. So revise the names of the organisms we discussed in bacterial conjunctivitis, and some of them, they cause hyperpion ulcers.
Staph aureus.
Staph aureus causes hyperpion ulcers.
Pneumococcus.
Pneumococcus is the word I'm looking for, because pneumococcus is the usual culprit in hyperpion. We will find pneumococcus in our examinations. Right. Similarly, again on this examination on slide, the examination to हम देख लेते हैं, but if we were again to this stuff over here, what were we to find in a bacterial, fungal smear microscopy or fungal culture? हमें कौन से organism मिलने चाहिए? In bacteria, we discussed there were pneumococcus and staphylococcus. In fungi, in fungal corneal ulcer, they can be
Candida.
Mucor and rhizopus. Mucor and rhizopus, they do not cause corneal ulcers as such. कराते हैं, but they're not important for us. They are more important or clinically important in the setting of diabetes, where they cause rhinosinusitis. So ENT में आपने याद रखना है Mucor and rhizopus. और कौन से fungi हैं?
Sporothrix.
Sporothrix Schenkia. Sporothrix Schenkia causes lymphadenitis in a case of thorn prick. This patient does not have lymphadenitis, and lymph nodes are not present in the eye. Aspergillus, and the third one is Fusarium, because it's not that high yield and micro, so मैंने भी नहीं पढ़ा था. So these organisms. Now, coming on to the slit lamp examination. We've already seen one important difference on the slit lamp examination. We've already seen one important slit lamp examination, but first I want you to look at the history of this patient. So we have our history of photophobia, redness, and tearing, which points us towards a corneal etiology of these symptoms. But there's something peculiar in this history. What is that?
Thorn prick.
So a farmer with a recent history of thorn prick, this is very important because it's a context clue, and UHS loves context clues. So thorn prick history and thorn prick injury to his eye. This is what is different in this history compared to our first case. So we have one important difference in history, and the second important difference is on our examinations. What was different on our examinations? Both are hypopyon ulcers, both have ulcerations in the cornea, both have hypopyons, both have circumciliary congestion, both might have KPs and all that signs and signs of anterior uveitis. क्या है इन दोनों में फर्क अभी?
Satellite lesions.
Satellite lesions, right? Satellite lesions are what differentiate in our two cases. In our first case, if you look closely, we can see a central corneal opacity with haziness surrounding it. In this it has luster. Luster means that whenever there's light shining on the object, it reflects light. And when we see an image, an object which is said to have luster or a glow, it appears whitish, white dots nazar aate hain hame, like reflect hote hue na. It's shiny basically what I'm saying. And when we look on this opacity, there's a bright beam of light over here, but it's lusterless. Secondly, there's a central corneal opacity with satellite lesions. So these are the characteristic findings in our cases. Our first case is of bacterial hypopyon ulcer. And the culprits in our first case is most likely the culprit is pneumococcus. It can be Staph aureus, Pseudomonas, and other organisms as well. So a bacterial hypopyon ulcer, it will be a typical hypopyon ulcer. There will be nothing special given in the history or in the examination. It will be a central corneal opacity with the hypopyon, with circumciliary congestion, my bad. But there will be one thing specifically given in the context of a bacterial corneal ulcer. In the history or examination, in the serial examinations, यानी कि examination एक बार की patient 2 महीने में आते 2 हफ्ते बाद आपके बाद आया तो in the next examination, they will tell you that the ulcer has wavy margins and it creeps across the cornea. This statement, the presence of wavy margins and the creeping across the cornea, this has led to another term being used for severe bacterial corneal ulcers. Bacterial corneal ulcer के ना दिया हो तो आपको ये term जरूर दी गई हो. And that term is, does anyone know what that term is? It's called an ulcus serpens. Ulcus means ulcer, and serpens, it means like a serpent. So, mushkil lafz hai, it's a buzzword, but it's not different. It basically means a bacterial corneal ulcer which has wavy margins and it creeps across the cornea. Creeps across the cornea ka matlab ye hai ki it will start in one place, let's just say around here, and after a while it will move towards another place or it will move the center. And its margins will be wavy like a wavy as a wavy. It's not wavy only. Okay? So the buzzword associated with bacterial corneal ulcers is ulcus serpens. You have to remember this. Take a time, absorb it. Ulcus serpens, bacterial corneal ulcer. So we have an ulcus serpens or a bacterial corneal ulcer that has wavy margins and it creeps across the cornea. Wavy margins creeps across the cornea. Our diagnosis is bacterial corneal ulcer. All right. दूसरे केस पे साइड बाय साइड चलते हैं. In our farmer who presented with a thorn prick injury, he has developed a lusterless ulcer, a central corneal ulcer on an opacity, whitish in color. Margins are somewhat distinct over here. All right. The peculiar feature is that there is a presence of satellite lesions. Now we know that satellite lesions are small lesions which are present around the main ulcer. So our diagnosis in this case is fungal hypopyon ulcer. Fungal hyperpyonic ulcers. You have to remember this because sometimes these are the only things which help you differentiate between a bacterial ulcer and a fungal ulcer. Patient with a fungal corneal ulcer, he will present to you with a thorn prick injury, or he's a farmer. He will present to you with a thorn prick injury. Other than the thorn prick injury, the patient can also present in situations when they are immunocompromised or the local immunity is decreased. Which drugs they cause a decrease in immunity?
NSAIDs.
NSAIDs, steroids. NSAIDs do not increase immunity; they decrease inflammation. You know that steroids, they decrease neutrophilic infiltration. They decrease they decrease nuclear factor kappa B, जो interleukins बनाता है. So they cause immunodeficiency. When the patient is on local steroids, he will develop or she will develop local immunodeficiency, and that is an important context clue in our case. So we know that now we know that in a patient, if we suspect fungal corneal ulcer, there must be either a history of a thorn prick in the patient, or there must be a history of local steroid abuse, a injudicious use of steroids. बहुत ज़्यादा steroids का इस्तेमाल किया. Other than that, the patient can be immunocompromised as well, systemic immunocompromised in case of neoplasms and in case of chemotherapy. So, our history में हमें differentiation दोनों cases में पता लगा. In our first case, we won't have any typical history, but in our second case of fungal corneal ulcer, we will have a typical history of a thorn prick or a history of abuse of or injudicious use of local steroids. All right. We will have the other symptoms. On examination, in our fungal corneal ulcer, we will have a central opacity, a central corneal lesion with satellite lesions all around. Satellite lesions all around, right? So on setup examination, there are a few important points or buzzwords which are important when we are looking for a fungal ulcer. The first we've seen is a central lesion. चलो central lesion को हम discuss कर लेते हैं. Important thing is satellite lesions. Satellite के spelling मैंने गलत लिखा है. अच्छा, satellite lesions के अलावा there are a few characteristics of the main fungal lesion, जो center में lesion होती है. It will have fungi में क्या होते हैं? Hyphae. Hyphae. So the hyphae they will penetrate under the intact cornea, meaning that ulcer तो वो है ना जहाँ पे epithelium खराब हुआ है, and there's no epithelium has eroded away. Some of the fungi, the hyphae, they will penetrate under the intact epithelium to produce lesions around this main central opacity. So how will you know that the hyphae have produced lesion and they're not actually corneal ulcers? कैसे हमें पता लगेगा? Staining से पता लगेगा. ठीक है, staining से पता लगेगा. When we will stain, the ulcer will be stained with sodium fluorescein. But those satellite lesions, if they are ulcers, they will also stain. But the hyphae, because they penetrate under the intact epithelium, they won't stain on the surface. They will not stain on the surface. Right? So it will have, the central lesion will have hyphae radiating from it. All right. So the central lesion will have hyphae radiating from it. There will be satellite lesions all around it. And a third finding is that there will be a ring, a small ring around a lesion, this whole lesion, or there will be small rings. Okay, those rings are important because the terminology is a buzzword. Those rings are called immune rings of Wesley. क्या होते हैं? I don't have a good picture for them, but we will see them or I will send you a picture of them if I find it after the lecture. So 3 buzzwords which are associated with fungal corneal ulcers. The first, satellite lesions. The second, radiation of hyphae or finger-like protections from the central lesion. And the third is the presence of immune rings of Vesely. And in this case, if we perform a smear and a culture of the specimen or scrapings, we will find that one of these 3 will be the leading candidates for which will have caused this corneal ulcer. All right, so 3 important things we've seen. And let's rewind these 3 again, and let's compare it to our bacterial corneal ulcer. So hypopyon ulcers, whenever you have a hypopyon ulcer, you should have 2 things in your mind. The first is a bacterial, and the second is a fungal etiology. How will we know whether it's a bacterial, whether it's a fungal? The first thing, is there any clue in the history? A bacterial corneal ulcer or a bacterial hypopyon ulcer, it will not have a buzzword or a clue as such associated with it. But in case of a fungal corneal ulcer, you will find a history of a thorn prick, or you will find a history of local steroid use. Secondly, there will be symptoms of corneal, there will be symptoms pointing towards a corneal ulcer such as photophobia, redness, and tearing. So coming on to the examination, if there's an ulcer with wavy margins and it creeps across the cornea, it's most likely a bacterial corneal ulcer. And if there's an ulcer which has hyphae or finger-like projections radiating from it in different parts, if it has satellite lesions, meaning that small lesions which are wandering around the central lesion, and if it has small immune rings, which are not visible in this picture, then our diagnosis will be fungal corneal ulcer. Okay? So the things you have to know on the history and the things you have to know on examination. A fungal corneal ulcer and a bacterial corneal ulcer. How will you treat these ulcers? मैनेजमेंट कैसे करेंगे दोनों की?
This internet connection isn't strong enough at the moment.
मेरा इंटरनेट कनेक्शन आई थिंक खराब है थोड़ा सा. आप लोगों को मेरी आवाज आ रही है? हेलो? आ रही है. अच्छा, how will we treat a corneal ulcer? What are the general principles we discussed when we were discussing the treatment of corneal ulcer the last time around?
This internet connection isn't reliable at the moment.
अब आपकी आवाज थोड़ी सी खराब हो रही है.
The internet is not working. So, how will we treat corneal ulcer or the treatment of corneal ulcer? What were the principles? Yes, exactly. What were the principles which we discussed the last time? So the first is based on the general measures. What are these general measures? आप हमें भी पता होना चाहिए, because the corneal ulcer पे जो सवाल आता है, the important thing after diagnosis is treatment.
This internet connection isn't stable at the moment.
Antibiotics.
Antibiotics.